Uh, uh, Welcome to the National Foundation of Swallowing Disorder webinar series. My name is Ed Steher. I'm the president of the foundation and also a head and neck cancer survivor. I want to thank you for attending our program this evening. The mission of the foundation is to improve the quality of life for all those with a swallowing disorder. And we do that through providing direct patient support, hosting educational events like this webinar, raising awareness, and promoting promising research. You will be muted during the presentation, and to ask a question, click on the blue question mark to type in your question at any time, and we'll get to as many of the questions as possible. Many of you may know that June was National Dysphagia Awareness Month. We did a lot of awareness activities on social media and with our webinar series, and we had a record number of sponsors that supported our initiatives during June. I just want to thank our sponsors for being there. One of the initiatives that we did during June was to share patient stories. And these were brief snippets of the lives of those affected by a swallowing disorder. If you haven't been out to our Facebook page or Instagram or Twitter, you might want to, and you're interested in reading the stories of those with a swallowing disorder, I think you'll find them inspiring. And the pictures you see here are only a subset of the stories that were shared during June. This webinar was made free of charge thanks to the generosity of an unrestricted educational grant provided by Bracco Diagnostics and also sponsors Cranial Rehab, Tim's Medical, and Mara GTX. Dr. Reva Beryl is a prosthodontist with 2 decades of experience in oral reconstruction. She is an assistant professor in the Department of Pulmonology and Critical Care at Oregon Health and Science University. She also founded Dr. Reva's Savories, a company that makes food products specifically geared to support the nutritional and emotional needs of people with dysphagia. Our second keynote speaker tonight is Dr. Samantha Hsu, an assistant professor and director of communication disorders and science programs at the University of Oregon. Before pursuing her PhD, she worked as a medical SLP in various medical settings with a focus on dysphagia and stroke rehabilitation. In addition to conducting research, she teaches and has organized a local swallowing disorder support group. Dr. Shin's research stands out due to her incredible focus on the patient. And at this time, I would like to turn it over to Dr. Reva Barrell, and then Dr. Samantha Shum will follow her. Just a heads up that Samantha's webcam seems to be acting up, so you may not actually see her this evening, but we'll work on it and see what happens when we get to her. And with that, Reva, please take it away.
Thank you, Ed. I hope everyone can hear me okay. You know, the audio working is probably the most important thing. So I just wanted to thank both of you for inviting Samantha and I yet again to your platform. We really appreciate it. We had such a fun time the last time, and we hope that the audience enjoys this topic, which is definitely a twist on what we had talked about before. And we're actually going to change the style a little bit of this presentation and make it more engaging with Q&A popping up in the middle of the presentation, and then at the end, bringing in Elizabeth to give some feedback, and Ed, definitely encouraging you to give your feedback as well to make this more interactive. And audience out there, please put questions in the chat. We'd love to hear from you. This is going to be a presentation that draws on emotion and just reflection on your own personal experiences. So we're really excited. The title of the presentation is Dining Health, a person-centered approach to improving the eating experience. And let's just see here if I can start out with some disclosures. The disclosure for me is that, yes, Ed mentioned that I do own a company that manufactures savories therapeutic foods. And the name of the company is Taste for Life. And I am CEO and founder. I'm also a member of the USTIRG task force in the US and territories for IDDSI to start disseminating educational materials and helping caregivers as well as team members in facility-based care and private practice support their patients with dysphagia. Dr. Samantha Shum is going to talk a little bit about, well, I can mention her funding sources are American Speech Language Hearing Association grant that she has received, and there's no other financial disclosures to make. As Ed was saying, I'm a prosthodontist, so I focused on full mouth reconstruction. Prior to being a dentist, I was a French culinary. Well, actually, sorry, I became a dentist and then I thought, hey, why not spend my afternoons and evenings learning about French culinary arts? So I became a French culinary chef. I love, you know, dabbling in many different things, and you can see that reflected in my background as a clinical researcher. I worked at OHSU, which is Oregon Health and Science University, as a teacher in dentistry. And then I saw issues with my head and neck cancer patients, and these issues related to food and food enjoyment. And then I began my exploration of food technology and thus developed Savory's Therapeutic Foods. I'm going to pass it on to Samantha to give her her introduction as well.
Thank you, Reva. Yes, and as everyone had mentioned, apologies, my webcam seems to be acting up today, but where would we be in the era of all our technology meetings if technology wasn't acting up? So Thank you all for joining us. My name is Samantha Schoen, and I'm currently an assistant professor and the director of the Communication Disorders and Sciences program at the University of Oregon. My work is really aimed at better understanding the shared mealtime and food-related activities as opportunities to therapeutically target not only improved longevity and health, but also improved quality of life, especially for older adults, healthy and otherwise. So feel free to visit our lab website for more information on some of the work that we are currently doing. So just, sorry, go ahead, Reva.
I'm sorry, I was just gonna advance. Sorry, go for it.
Yeah, and I was just going to say, just to give a bit of an overview on what we are going to be talking about this evening. And Reva, if you'd like to click ahead to the agenda. So some of the things that we hope to cover tonight under this broader umbrella of dining health is talking about eating with our senses, talking about how sensory deficits compound the risk of malnutrition, especially in the presence of dysphagia, talk a bit about caregiver burden and dysphagia as the contextual information or environment that is happening when an individual has dysphagia, provide an introduction to transitional foods as a novel texture to improve quality of life and nutrition, and then to end with some tips for improving the dining experience.
So I wanted to let you all know that Elizabeth has a lot of handouts for you. One of the handouts is going to be the presentation itself. So those emails and connections that you might want to make to Samantha or myself are going to be easily accessible by you. Let's talk about why we eat. If we look at why we eat in health, we can start to see that it's really broken down into two components, the emotional and then the nutrition. The emotional being the want behind eating, and then the nutrition being the have to behind eating, right? We need food to survive. We need to have the right foods to survive and be properly nourished. But you know what I find very interesting is this focus on emotional, and where does that come from? Where does that want come from for eating? And really we discover that it's very complex. If we go into the food science literature, we can see that it's wrapped into this, you know, this web of family history and culture. It's basically used to show love. It can be a creative expression. It can symbolize a change of seasons. It can be tied to religion and beliefs. And in a sense, it becomes our identity. And so, you know, we really need to understand this as we start to kind of delve deeper into the realm of dysphagia. And I think that Dr. Brene Brown, who is a social worker, a doctorate, an emotional intelligence and vulnerability guru. I don't know if you've read her books or listened to her podcast, but I think she's quite wonderful. What she says speaks to this emotional aspects of eating. Because what she says, with everything in life, we like to think we are rational beings who occasionally have an emotion and flick it away to carry on being rational. But we are emotional, feeling beings who on rare occasions think. So in looking at that, you know, it makes me reflect a little bit on when we have a patient present to our office that has dysphagia, and we are concerned about their nutrition, just understanding the backstory of food is very important. In the emotional aspects will increase compliance if we address those issues as well. Really going into food science even further, we see the sensorial pleasures, which ties into that emotional reason for eating, is really founded on our five senses. Because if you want a home run in making food for someone, you would hit all of these five senses. And, you know, the question is what of these five senses are affected the most with a modified texture diet. And I would say, in looking at all of these 5 senses, all of them are affected when you have a modified texture diet. And I really hope today we talk about what we can do to bridge some of these deficiencies. So, let's just break it down. The vision right there, we have a pureed food that's molded. 3D molding is like is a way that we compensate for the lack of vertical height, the lack of appearance and identity of foods when they are pureed. The taste factor is very important because taste is related actually to hearing, it's related to smell. So none of these senses occur in isolation. I want to make sure that's clear. And also the fact that when puree is blended in a mixer, then you do lose a lot of those volatile oils that occur in foods, and those compounds, those chemicals that actually aerosolize. They go into the air, but they don't go into the mouth, right? So that a lot of that smell gets lost before it actually even hits the plate. The hearing aspects are really key with dysphagia because we lose that auditory stimulus. And the touch factor, many of our foods, we use indirect touch. We use forks and spoons, and well, basically that's what we use, forks and spoons, when we have a modified texture diet. And that direct touch, which I mean is fingers touching the food, is lost. And we'll talk a little bit about bridging that gap with transitional foods. And of course, the smell. So I'm going to ask the audience, which is your favorite food texture? Do you like foods that you can crunch, that you can chew, that you can suck for a long period of time, or foods that you can smoosh? And I ask you this because really what we want to understand is that before, if you acquire dysphagia, before you have dysphagia, you might have a preference of, say, crunchy and chewy textures. What I can tell you is Geltima in 2014 published that the majority of people prefer crunchy and chewy textures. 80% prefer crunchy or chewy textures. So that's a lot of people out there that if they develop dysphagia, they would lose their preferred texture. And so this can be more impactful for those 80%ers that have that texture preference versus the ones that prefer foods that they can smoosh or that they can suck. Now, let's talk a little bit about texture and history and food history or your food story, because this is an interesting study that's now going on. And this is really examining the textures that are all these textures here would fit into a modified texture diet. But the people looking at these textures will not be tasting the food, they're just looking at the food. And they're developing an emotional response to that food even before they put it in their mouth. So this speaks to food rejection and the importance of us actually looking at that presentation of that food and how, like we said, we eat with our eyes. That visual is really important. Really, the texture is perceived visually first before it's perceived in the mouth. So again, there's that interplay of all the senses that researchers are now looking into to see how do we improve the eating experience for people with dysphagia. And we can't, look at the older Americans and say, oh, well, eating choices, what they prefer to eat, it might not be as important to have nutrition, a high nutrition diet, or, they might not be as diet focused, because the truth is that's a complete fallacy. Older Americans are more likely to adopt healthy eating behaviors than younger Americans. They look at nutrition facts and ingredient lists when they go shopping. 71% of adults age 50 plus describe a healthy eating style as the right mix of different food groups. Yet the largest group of people requiring a softer diet are over 65. So now you can see that patients coming into the practice that might have dysphagia, they are looking at nutrition facts. They are looking at ingredients. Nutrition is important. Healthy eating is important. It is a very important subject to talk about. Why is malnutrition a risk with dysphagia? Well, let's break this down, because I'm going to look at it from the emotional aspects, because you can go into malnutrition in many different ways. But if we're going to like hone in this conversation to the psychological impacts of dysphagia and the sensorial impacts of dysphagia, it plays into food refusal and the risks associated with that, which are malnutrition. So looking at this, article by Martino in 2008, they broke down what is the response to dysphagia from an emotional perspective. Well, first of all, something has happened to their body, the structure, their function. Then comes eating and drinking has changed. That's the result of something happening, and eating meals together has changed. So it's really important to look at this and say, hey, that eating experience is going to be altered for that individual. Emotions come into play that were never there before they had dysphagia. Negative emotions like fear, depression, embarrassment, frustration, vulnerability are emotions described in this article. And then we have to look at the emotions when they're eating with another person, because that's how the eating meals together changes dramatically, and Samantha will discuss this further. So we all know that there's difficulties with a modified textured diet. There's forums on Facebook that people are sharing their frustrations, their solutions, what they're doing to create their, what they call their new normal of what they can eat, and trying to develop community with regards to this. But what's very clear and apparent in these Facebook groups, Instagram posts, and also in our literature is that texture fatigue, palate fatigue, difficulty in preparation, loss of food recognition, and the doubt in the effect of a modified texture diet are all players in that difficulty in adoption of a modified texture diet. So if we look at a food on a plate that's been pureed or even minced moist food, we can see there's a loss of color vibrancy. I mean, the thing, an example I want to give is a recent Facebook post. You know, someone was making a meal for themselves and they really needed advice because they would blenderize and they lost the color vibrancy by mixing everything together, the meat and the vegetable and the starch. And then, you know, they were thinking they were getting everything to the right texture, but in blending everything together, they lost the color vibrancy. You actually lose taste when you blend everything together. You get flavor dilution when you add broth to get the right thickness. Of course, the loss of the food sounds goes away. So we have really, honestly, all five senses are affected when, as I said before, with the modified texture diet. And so when we look at this, we kind of look at this. This is a plate from a hospital, and this is the end of their breakfast. And you can see how plate waste can be a major player and oftentimes can reach up to 70% of the meal is wasted. And even a physician who recently had COVID, a transplant specialist, really talked about his experience with COVID, and he was on a ventilator. He almost didn't make it. And what he said was memories that he had were, you know, largely focused on this issue of the modified diet he had to experience. And you can go to this article and read it because it's a great article. But what he says is, I can be much more on their side, in their shoes, in their thinking. He so disliked the thickened liquids used to help restore swallowing ability that now he is less inclined to push them on reluctant patients. It just tastes so horrible, he said. I really cannot blame anybody who cannot take it. A few weeks ago, a patient complained about the thickened milk. In the past, I would have just said, you have to do this to get better. Now I can say, maybe you don't have to do it. Each patient may have a different way. So it just, again, brings to mind this his food memory and how he, as a doctor, is looking at his patients a little bit differently now. The typical pureed diet, back to malnutrition risk, article after article is talking about the risks of less protein than a regular diet with puree. So we really have to look at the dilution properties of not just the flavor, but of the nutritional macro and micro content in these meals. So we can talk about ways to improve that later. But really what we're looking at again is the research that talks about the protein and fiber and vitamins D, K, and E, folate, magnesium, calcium, potassium, zinc, the total caloric value, and of course the hydration, all risk factors for being lower in a soft diet or a modified texture diet. So here I wanted to just tell you that, like, going broadly, there's compounding risk factors for a patient. So not only do we have, a lack of sensorial enjoyment of the food, a risk factor of perhaps the nutritional aspects of the food, the micro and macronutrient content, but for that individual who's receiving that food, we have to look at their potential for physical impairment, the ability to self-feed, to even open packages, the altered taste perception they would have, and I'm going to go into that in a little bit more detail, and perhaps their cultural heritage and their relationship to food, and what we can present to them as far as food choices in facility-based care. Do we approach this when you have your puree that might be stripped of food identity, layer that on top of cultural identity, and then we can have a further distancing of that individual from the food that's presented. And of course, the mental status of that individual as well. I'm going to put my dentistry hat on right now, and I think this would be very interesting for you all to know that when we talk about taste, people think of taste on their tongue, right? And that's how we perceive taste, right? And taste perception changes with age. But did you know that our taste perception actually diminishes with denture use? So if you have someone with full dentures, upper maxillary dentures, there are minor taste buds on our palate that are completely covered by the denture itself. Did you know that the thermal properties, you have a hot coffee, hot tea, that is in the sense that those thermal properties, your tissues are insulated from that by the denture. So you lose that the thermal stimuli of your food as well. And believe it or not, if you have poor oral hygiene and you have bacterial growth in the mouth, not only on the tongue, but on the teeth themselves, this can alter your taste perception. Anosmia and ageusia, of course, these are factors from medications or disease. COVID-19 has really resurged. There's been a resurgence of interest in dealing with these factors, as well as xerostomia. Did you know that dry mouth is linked to diminished taste perception? So if you have less saliva, and believe it or not, 38% of older adults have less saliva, and that's without medication influence, without head and neck cancer influence. This is significant in the older adult population. Now let's compound that what is a risk factor of less saliva in your population base? And what does that saliva do? Well, you know, I'm just going to narrow it down because I could probably put 20 things here of what saliva does. But if we're talking about taste, it modulates the perception of oral sensation, the viscosity of the food, the taste of the food. It helps to release those aroma compounds, and in fact leads to chemical reactions in your mouth between different compounds to produce a new compound, which in a sense gives you that secondary aroma in your mouth and secondary flavor in your mouth. And it also forms that bolus. You know, the mucins combine with the food and helps in mastication and creating that slippery bolus to help with the swallow. And of course, the oral clearance through dilution. So you can see here that there is a cycle that happens in the dental realm, and you can see how this is actually influential on the realm in dysphagia. Because if you have a loss of teeth and you have decreased function, you actually have muscular atrophy in the muscles of mastication. You can have improperly fitting dentures, or you can just have a loss of teeth, leading to the need to modify the texture of your diet. And I won't say that this is everybody, but many people suffer from this consequence. And the result can be nutritional deficiency. If you are nutritionally deficient, it can impact your gingival health and impact your wound healing from oral surgical care, and essentially lead to further bone loss, which then impacts, again, the loss of teeth. So I'm going to share with you this idea of amalgamation of information from dentistry and dysphagia research is really important because we're not that far away. You know, what happens in the mouth, the next thing down is what happens in the throat, and really the impact of the oral processing is, you know, very much so a part of your literature. And I'm really excited about this idea of a dental screening questionnaire where, you know, we are looking at oral frailty scores using, you know, it's kind of nice that it says dental, but it's dysphagia, eating difficulty, no recent dental care, tooth or mouth pain, alterations or change in food selection, lesions, sores, or lumps in the mouth, all having point system. Now, this requires validation, but it starts us thinking of different types of, there's a multitude of oral frailty scales out there. And I really think that this is an interesting way of bringing together dentistry with dysphagia. But I'm going to propose to you, and I'd love your opinion on this, of a screening tool for food refusal risk. This is a thought process I wanted to share with you of putting together some of these things that we're talking about and actually looking at perhaps creating a new point scale, looking at risk factors of the altered taste perception, looking at the age of the individual as perhaps having, you know, that impact, the impact of age on our taste sensation, which I didn't really get into, but there is an impact. The denture use, the poor oral hygiene, xerostomia, gusia, anosmia, all things that we talked about today. But then looking also at the potential for dysphagia leading to food refusal risk through loss of food recognition from a texture modified diet, eating fatigue, texture fatigue, negative emotional response that I shared with you earlier of the fear and the embarrassment and the frustration, all leading to potential food refusal risk. But then adding to that the physical impairment, perhaps the loss of manual dexterity, perhaps the pain involved in eating and swallowing. Neurocognitive decline goes into the mental status of the individual, and adding that to your risk factors. The ethnicity, are in the facility that they're in, is there availability of culturally appropriate foods that really speak to their ability to identify with the foods, to relate to their meal. The flavors, are they reminiscent of the foods that they used to enjoy. And the timing of eating, there is ethnic diversity in times of eating during the day. And finally, food engagement. In the past, before they had dysphagia, did they participate in the shopping, in the chopping of the foods, the participation in preparation, the cooking of the meal? Was that part of their enjoyment? And so really, if someone really wasn't involved in provisioning, they weren't involved in preparation, their connection to their food in this category was not as strong, then really it plays into the idea of our emotional connection to our food and the risk of food refusal or food abandonment when there are difficulties and struggles. So, I'm going to finalize this section by saying there's factors influencing food acceptance in health. This comes from literature that dates back in food science. And they looked at, what makes us accept our food? How can we break this down? And I tried to break down a little bit more broadly into those emotional and nutritional needs. But looking at it in a more granular perspective, we can see that there's choice antecedents. And what they mean by this is, what do we bring to the table? Well, what we as individuals bring to the table is a perception of ethnicity, the level of involvement, the perception of variety, our behaviors, our food neophobia. Do we have food neophobia? Our prior experience with the meal that's presented to us, our expectations of what it's going to taste like, and our affect. And then we look at our eating environment. What was the effort to obtain the food? Was it easy? Was it difficult? The socialization aspect around food, the visual appeal of that food, the packaging, the menu appeal, even music. So you combine those eating environments, and then you can really see how that distills into a yes-no response of that individual to the food that's presented. So I'm going to just take a little pause here because I think it's a great time to bring Ed, Elizabeth, and Samantha and you all into this question and just see if any of this material relates to your, to your practice, or if you can give examples of some issues that you have seen or you can think of related to putting when your patient does go on a modified texture diet.
I think, Reva, I'll chime in first here if that's okay. And
Yeah.
one thing that I really think about as you're talking is that we focus so often on the dysphagia and the dysphagia itself. And I think what I really like about this diagram and what I really like about what you've said so far is dysphagia is one piece of the bigger picture. And so we really need to be paying attention to response to our recommendations, response to what's going on. We need to pay attention to how the dysphagia is interacting with some of these other variables. So for example, in this eating environment here, you said effort to obtain food, and you specifically said, as part of your question, texture modified diets. And I think that's difficult. Sometimes it's really difficult to obtain special foods for whatever reason someone needs it. So again, that's going to make it less likely that they're going to successfully follow the recommendations that a clinician has put forward. And so I think, for me, this is right up my alley, totally what I talk about and what I feel is important, but really recognizing that this is just one piece among all these other factors that are going on, even in typical health too, even as you and I decide, whether we're going to eat something or not.
Absolutely. Yeah, I mean, I look at, some of this work by Geltema on those crunchy textures and looking at preference, and it's really interesting to contemplate, what would be the psychological impact if you took away those textures from someone whose true enjoyment from the food came from texture. So it's like almost, creating a classification or identifying risk based on your history with food. And that can even go into like different cultures. You know, it's interesting that when someone does have dysphagia, a lot of times community comes together and they want to help them, they want to support them, they want to bring foods over that are comforting foods. Well, the truth of the matter is a lot of those foods might not be the appropriate texture for that individual. And depending on culture, you know, it brings to mind, like, what are the typical foods that you want to eat when you're not feeling well? And how distant are they from a texture modified diet that's appropriate for that individual? And so the struggles are real to kind of, you know, look at all the different factors that would affect from an emotional perspective, as well as a food preparation perspective, and volition to, you know, to make these changes that are necessary in order to stay compliant with your diet and be satisfied. So Elizabeth, did you have anything you wanted to add in there?
Yeah, I was just taking a look here. We don't have any questions in the chat, but I was just going to share a quick anecdote from earlier this week, working with a couple where the husband has dysphagia. He is a retired baker, spent his whole life in a bakery. So, you know, smells are important to him, meals are important to him. And so what he has done now with his modified diet, he still loves the smell of cookies and sweets and bakery items. They have found some large candles that they light that fills the house with those smells. And for him, that's very helpful, especially around meal times. But I would imagine that for other people, just that smell might trigger, you know, negative emotions around mealtime with that. And we do have a question here asking for some advice. Let me read this here to you. It says, what advice do you have if we are told to just make diet recommendations that are appropriate texture-wise and leave the nutrition aspect to the dietitians? Should we make our recommendations within our scope and then let the dietitians make their recommendations to compensate for any lost minerals and vitamins, or how should we best work together on that?
Yeah, Reva, if you don't mind, I'll take that one first to start. And I mean, I think that's a really valid question. And I think some of the things that we're talking about and that we're going to talk about is a paradigm shift. It's a paradigm shift from seeing the speech pathologist as assessing and treating dysphagia in isolation, and the dietitian assessing and treating nutrition in isolation, and the dentist assessing and treating, you know, oral hygiene and teeth in isolation, and really moving towards this model where we have to think about dining health as a multidisciplinary effort. And I think because there is so much overlap, these go hand in hand, because central to this entire conversation is the patient and what the patient wants. And so if we're, you know, each discipline is individually making these recommendations, who's having a conversation with the patient about how all these recommendations come together? Now, I know that's all great in the ideal world, and how does that help in day-to-day clinical practice? I think it still comes down to having those conversations. I certainly, you know, think it's not within our scope of practice to make recommendations about, oh, you need to be, you know, hitting this protein mark every day, and you know, that is not within our scope of practice, but it certainly is within our scope of practice to talk to the dietitian about what is their protein mark. And then we can have a conversation with the patient and say, you know, what are you eating? What's available to you? How can we work towards meeting that mark? And so I think it comes down to a lot more communication across disciplines ultimately.
Yeah, I 100% agree with Samantha that working in isolation will never lead to progress. And this idea of texture, I mean, SLPs are the experts on texture. And, you know, we just had conversation about how texture can't be seen in isolation. Like you can't look at just the texture properties of food. It's so complex. And so, you know, I really think that conversation needs to broaden. And what I hope is that through this context of the psychosocial aspects of eating and eating enjoyment and texture, you start to circle into having those conversations with a dietitian and saying, hey, you know, these impact nutrition. We need you to guide us into nutritional choices for that patient, but we understand and are wanting to talk more about this person-centered approach that includes their history and includes their texture preferences, so that we can get them to eat and eat with enjoyment, which will compel them to maintain a diet and prevent malnutrition. I think this would be a great time for Samantha, if you want to move on to the next slide.
Yes, thank you. So what we're going to move now into is really, again, applying this to dysphagia and applying some of these more broad concepts related to dining enjoyment and meal times and food and what happens in the presence of dysphagia. So as Reva introduced just moments ago now, there are a variety of factors related to food acceptance and health. When we consider dysphagia and dysphagia management, we really still have to attend to these antecedents of the eating environment. However, we also have a number of other barriers to consider, such as safety, availability, accessibility, negative emotions such as fear, embarrassment, confusion, and also caregiver burden. And so while we certainly won't cover all of these variables this evening, and you're always more than welcome to reach out to either or both of us to continue this conversation, I do want to take a bit of time to explore a few of these in greater detail as we move toward a better understanding of optimizing dining for individuals with dysphagia. Next slide. So allow me to start perhaps most broadly for a moment and really look at some of the factors in the eating environment that are also related to the emotional aspects of the meal, and that's caregiver burden. Today, more than 1 in 5 Americans are caregivers, having provided care to an adult or child with special needs at some time in the past 12 months. This totals an estimated 53 million adults in the United States, up from an estimated 43.5 million caregivers in 2015. We certainly see a significant increase in the number of caregivers of both children with special needs, as well as a significant increase in the prevalence of caring for a family member or friend who is age 50 or older. We also know that supporting individuals in living at home, despite the presence of medical conditions that may prevent them from being able to independently care for themselves, is hugely beneficial. So for example, older adults that reside at home have a significant reduction in mortality rates. They have increased feelings of security and familiarity and are better able to maintain informal relationships and interactions. Yet despite these clear benefits, little clinical attention is actually paid to the caregivers themselves. Next slide. So unfortunately, informal caregivers do experience higher levels of emotional, financial, and physical difficulties, which ultimately impact their overall health. As a consequence of caregiving, these family members often suffer from symptoms of depression and anxiety, even decreased immunity. Caregivers are also less likely to monitor their own health, and caregivers may actually be the most vulnerable member of the family. We also know that poor caregiver well-being can negatively impact care recipient health, and so this cycle continues. So ultimately, the physical health and quality of life of both the caregiver and care recipient are interdependent. Really what this means is that this model of care is not sustainable as currently practiced. So informal caregivers are not only members of the support team, but are also individuals with their own needs. Reducing sources of burden is a health priority, as we often rely on these informal caregivers. And yet prior to intervening, we must first identify those risk factors for increased caregiver burden. So next, I want to talk specifically about caregiving and dysphagia. And really interestingly, previous research has suggested that swallowing impairments themselves may contribute to such burden among carers of individuals with head and neck cancer and neurologic diseases such as stroke, due to a variety of dining-related factors. So these family members of individuals with dysphagia experience increased feelings of anxiety, burden, distress, fear, frustration, sadness, and isolation, which really mirror some of those negative emotions that individuals with dysphagia themselves are experiencing. These individuals talk about feeling a loss of social bonds, decreased life satisfaction and quality of life, and talk about having to negotiate a new normal. And so if we're looking at the larger picture of dysphagia and food acceptance and broadening our view of the mealtime process, we certainly have to consider how the caregiver plays a role in this as well. And so what I've listed here are just some of the feelings that these caregivers have reported across the previous literature. So for example, they report increased fear and anxiety related to the responsibilities, their care recipients' nutrition status and choking. They talk about needing increased conscious thought and intentional activity for meal preparation, which is a crucial part of the mealtime process. They talk about meals lacking togetherness. They often report that they eat alone or eat in secret so as not to upset their care recipient. Many of these caregivers talk about having a lack of support overall. So I think the example Reva gave previously where, we want to support individuals in the community if someone's going through an illness, but people don't always necessarily know how to support them. And so these caregivers, when someone's in the hospital, they're getting round the clock assistance from nursing staff, and then they go home, and who's there to support them or help them out? And then certainly they report feeling fearful and uncomfortable trying to balance safety concerns with patient food preferences. And food preference is a big topic that we're going to continue to talk about today as well. So Nund and colleagues, Rebecca Nund and colleagues, have really delineated the third-party disability or the disability of family members due to the health condition of their significant other that is experienced by caregivers of individuals with dysphagia. Notably, this research and the previous studies on family members of individuals with dysphagia has suggested that dysphagia results in widespread activity limitations and participation restrictions among caregivers and family, as well as certainly among the individuals with dysphagia themselves. So our recent work supports that the general burden experienced by caregivers of individuals with dysphagia is a consequence, at least in part, of the presence of dysphagia itself. I have been involved in a number of studies that have used data from the National Health and Aging Trends Study and its companion, the National Study of Caregiving, which are two linked population-based longitudinal studies of Medicare recipients and their caregivers in the United States. And through our analysis of this data, we examined the type and extent of caregiver burden that's uniquely experienced by those spouses and adult children caring for their loved ones with dysphagia. Significantly, even when accounting for other factors known to influence burden, so age, gender, health status, we found that caregivers of spouses with dysphagia were over 2 times more likely to experience emotional burden. They were also more likely to report having little time to themselves and feeling depressed as compared to caregivers of individuals or of spouses without dysphagia. Similarly, caregivers of parents with dysphagia were about 1.6 times more likely to experience emotional burden and 1.7 times more likely to experience physical burden. So really, this has been the first work to reveal that the presence of dysphagia is an independent predictor of increased burden among individuals caring for family members. These findings also support that the third-party disability that I described before experienced by these caregivers of individuals with dysphagia is a consequence, at least in part, of the presence of the dysphagia itself. So importantly, these results have really supported our call for the need to shift the status quo in dysphagia management and our clinical practices to focus on the joint lived experiences of patients and their families. And while we'll talk a bit more about strategies to implement and clinical considerations later, based on this research, it really is clear that in order to help mitigate the burden felt by caregivers of aging adults, it is crucially important that healthcare professionals identify swallowing impairments early on and that we treat them. Further, I think as we think about the field of implementation science, it's clear that in order to maximize intervention outcomes, we must consider comprehensive management approaches that ensure that caregivers do have the tools that they need to support our patients and that they themselves feel supported as caregivers. Next slide. And, truth be told, we have a fundamental issue in dysphagia management. So recall Reva's previous discussion about why we eat. So being the scientist that I am, I did a really scientific search of Google Images, and I typed in words such as eat and eating and mealtime and food. And what we found in searching these images is that so much about the mealtime is incorporated into that. So looking at these images here on the left, they appropriately capture the essence of these words. We see variety in the food eaten and who it's eaten with. We see engagement and interaction. We see emotion present in these pictures. We know that shared meals can reinforce our physical, our psychological, our emotional connections. We know that humans connect food to rituals, to symbols and beliefs. Individuals reaffirm, transform, and maintain relationships with others. We also know that mealtimes are a cultural site for the socialization of individuals, such as children, into appropriate and competent members of society. Now, unfortunately, when we introduce dysphagia into the mix, all of that seems to disappear. So on the right-hand side of your screen are the top Google images that pop up when you search for the word dysphagia. We've taken away that variety. We've taken away that togetherness. We've taken away that emotion. We've taken away the food itself. And we've reduced it down simply to a schematic diagram of the head and neck showing an unidentified, mass of something moving through the mouth and the pharynx. And so I think we're really losing something, or losing something arguably that's most fundamental and crucial to the eating process, when all we think about dysphagia is on the right-hand side of the screen here. Next slide. So then, how do we improve choice antecedents and the eating environment while reducing dysphagia-related barriers to gain food acceptance? We're gonna next, I'd like to dive in a little bit more into some of the specifics regarding what we know about the additional contributors to food acceptance. So there is growing recognition of the importance of increased eating frequency and individualization of care when it comes to ensuring dining success from both a nutrition as well as a psychosocial perspective. Yet increasing eating opportunities successfully, so doing that successfully, is really reliant on a number of factors, including accessibility, availability, preference, and safety. And really little is known about patient perception of these important factors. Recognizing this need, we recently conducted a qualitative study that was aimed at identifying food and snacking preferences of nursing home residents and barriers that they encounter to getting these needs met. So while the results I'm going to talk about now are based on a nursing home study, I really do think many of the sentiments expressed by the participants are translatable across settings. And while I won't cover all of these aspects today, it's really important to keep in mind the role that all of these components, accessibility, availability, preference, and safety, really play not only in food acceptance, but also in health and well-being. And so we conducted 17 interviews across 10 residents residing in a care facility. Really, the interviews that we conducted were focused on food more broadly and food preferences, but also specifically on in-between meal snacks. So an often perhaps underestimated and underutilized and under-researched opportunity for, again, increasing eating frequency, increasing opportunities to have a successful dining experience. And the goal of these interviews were to explore not only what individuals' food preferences were and whether those needs were currently being met in the nursing home setting, but also what individuals hoped would be different and what individuals really see as some of those most crucial aspects of food. So one of the key themes that emerged related to residents' desired qualities of food is that food is not only a sensory experience, but a full sensorial experience. So Rava, if you can click the next bullet, thank you. So the importance of taste and texture and smell and visual appeal, all of these senses came out in the interviews. All of these were deemed to be very important to experiencing and having a pleasurable eating experience. As one participant said, there's no real point in eating if it doesn't taste good. Another noted that people respond to food that looks different. If it's not recognizable, people won't eat it. Not only was the importance of these senses individually noted, but also the importance of these senses working together to make a pleasurable eating experience. So it's not just having good tasting food. It's having good tasting food that's the texture that someone expects, that smells pleasing, that has the visual appeal. A second theme that really emerged, and I think speaks of clear relevance to some of what we're talking about today, is that opinions vary. Not everyone has the same preferences for what they desire in food and what they desire in snacks. So many participants noted that they preferred to have healthy snack options, so things like raw fruits and vegetables, things fresh out of the garden, as one individual noted. The less time it's touched, the less processing that happens to it, the better. But then look at all the variety in this next bullet here. One person says crisp and juicy. A number of people say crunchy. Someone else likes chewy. Someone likes sweet and salty. Another person likes salty. But then another person says not really salty, savory. That's not hot. While two other people like spicy. Someone likes milk chocolate and white chocolate, and she'll eat dark chocolate only if that's what's been given to her. While another person likes good taste without getting too sweet. And so what this says here, it's almost impossible to have one standard, to have one option, if we really want to take into account what individual preference is. And that's a dilemma often in dysphagia care, and that's often a dilemma in institutionalized settings where you have to have some sort of standardization of meals and standardization of snack time. Next slide. So talking a bit about the implications related to dining when we think about these desired qualities, of course, preference can sometimes be at odds with safety. Likely, this poses more of a dilemma for us as clinicians than a perceived dilemma for our patients, as individuals want to eat what they want. So how do we balance safety concerns with clear food preferences? Unfortunately, what this often results in is a loss of autonomy of choice, where the healthcare team places greater value on the safety concerns than the patient preference. And this comes back to what I said earlier about having to have those conversations and really having to identify what is a patient asking for? What is their choice? Can we elevate patient autonomy? Additional considerations that stem from these findings relate to identifying food as food and food matching expectations. So based on previous experience and based on preferences, all of us have a picture of what food should look like, taste, smell, and feel like. And often when a diet gets modified secondary to a dysphagia diagnosis, those key properties of the food get altered, sometimes beyond recognition. Not only will this reduce the enjoyment associated with meals and eating, but it can also lead to an increased risk of malnutrition due to poor acceptance. So for example, familiarity is often of great value for individuals with dementia. If they do not recognize what is sitting in front of them is meant to be eaten because it doesn't match their picture of what food looks like, or does not match their expectations for what food should look like, then they simply will be less likely to eat it. And I think certainly these risks are not limited to the dementia, population alone. We all make choices about what we eat based on our desired qualities and our expectations of what a meal should be. And so when these expectations are not met, for myself, when a recipe goes wrong, as commonly happens, or if you have a poor meal at a restaurant, or a dysphagia diet or a dysphagia meal that is all, quote unquote, beige slop, we're just not satisfied physically with that meal, and we're not satisfied emotionally with that meal. Finally, and relatedly, as was mentioned before, there are certainly the risks associated with neophobia, or the fear of something new or unfamiliar. And so when we change the dining experience through, for example, food modification, limited food options, newly introduced textures, nutrition supplements, individuals may be more likely to reject this experience. So going to the next point, another key concept that emerged in the qualitative study was that we may need to be thinking more broadly about dining and nutrition. So whereas the focus is often on the traditional 3 large meals per day schedule, residents in our study clearly noted the benefits of snacking. So one individual mentioned, I think that snacking is really good and good for a person. Snacking can be very positive. The same individual talked about how a snack can really pick you up in between meals. And a different participant had noted that snacks can really be a powerful alternative to the more traditional 3 meals per day, really allowing you to kind of throughout the day snack a little bit. And so this is perhaps a shift in mindset that we need to make to look at how else can we enhance dining health beyond the kind of 3 meals per day. The last piece that I'm going to talk about specifically is the importance of socialization. So another key element that came up in our interviews was this idea of socialization and food being intimately linked. So anytime anyone serves food without socialization attached to it, they do not have an understanding of food. They just don't, because that's equal to or more than, the food itself. So what this leads me to is a little bit of information on the link between socialization and nutrition, and how we might need to be thinking about, again, that dining experience when we're also looking to enhance intake and enhance nutrition. And while numerous age-related physiologic changes do negatively impact food intake, social and psychological factors can certainly play an important role as well. Who you're eating with, where you are eating, can all impact what you eat, how long you eat for, the satisfaction you had with your meal, the overall mealtime experience, and these can all play a role in overall nutrition as well. So I pose the question of, should we be considering nutrition as isolated to the individual alone? For example, we know that eating in company enhances the emotional experience of dining. We also know that social companionship is associated with greater food intake. So the amount someone consumes during a mealtime is impacted by situation and the characteristics of the person they are interacting with. So I want to wrap up this by talking about one final series of studies where we explicitly looked at whether we could manipulate intake based on the behavior of someone else. And so the first two studies that were done here, we're looking at whether we could get participants to drink water more frequently, not during a meal, during a completely unrelated conversational task, just by simply having the person they were talking to more frequently drink their own water. And what we found, so this first slide here was just with healthy younger adults, so just typical 18 to 30-year-old adults, was that when they were sitting there engaged in conversation with someone who was purposely trying to drink more frequently, the participants also drink more frequently, as well as spent a greater percentage of conversational time drinking. The next slide here shows that we found similar results among healthy older adults. So again, when they were sitting there just having a conversation with someone, and that other person was purposely trying to drink more frequently, these healthy older adults, again, drank more frequently and spent a greater percentage of time drinking water as compared to when that other individual was just touching their cup and not explicitly trying to drink from their cup. So this finding was really exciting for us. And so what we next did is said, well, hey, can this apply to individuals with dementia as well? Can we actually use this as a strategy, use this socialization aspect as a strategy to enhance dining and increase nutrition? And so this is literally hot off the presses. Stay tuned. This data will be coming out, the study will be coming out in the American Journal of Speech Language Pathology shortly. It is in press. And so what we did here is we wanted to look at the impact of environment on intake. And we collected data from 4 nursing home residents, a mean age of about 83 years of age with dementia. And we weighed their food and liquid intake across 15 meals and 3 different mealtime conditions. So one point in time was just when they were eating by themselves, their typical eating environment. Then we had another condition where someone was sitting with them and socializing with them, but that individual was not eating. And then we had a final condition where someone was sitting with them, socializing with them, and also eating as well. And while the data visualization, so the graphs, the analyzing of these graphs themselves supported a weak functional relation between eating environment and the amount of intake consumed, our statistical analyses, our log response ratio estimates suggested a trend for increased weight of food consumed during the eat condition as compared to that eating alone condition and as compared to the condition where they were just socializing but not having someone else eat with them. And so these results really preliminarily support the benefit of a visual model for increased consumption in some individuals with dementia. Now, the presence and magnitude of this effect across conditions varied based on individual level factors such as cognitive status, which does have implications for implementation. But overall, that study really provides an initial proof of concept regarding the use of visual modeling as an intervention approach. And so what are the implications of these findings? Ultimately, engagement matters. The ability to be eating with others, watching them eat, sharing a meal is a valuable biopsychosocial experience, incorporating all aspects of it, nutritional intake and psychosocial well-being. Now, of course, this cannot be just blanketly applied. So for example, some individuals in that nursing home study did do worse when eating in the presence of others when that person was not eating. So we certainly need to consider distractions, cognitive abilities. Additionally, I mentioned patient autonomy before. We cannot always assume that we as a professional know what's best, and rather we have to engage in a conversation about what we recommend and how that is aligned or not aligned with what that individual prefers. But ultimately, it is important to be considering that socialization aspect of the dining experience. So to conclude my portion here, my portion now, really considering the bigger picture that we've been talking about, we've started to use this term dining health. Because if we can create and offer foods that meet not only the nutritional needs of our patients, but also their emotional needs, we will likely have more success with acceptance, adherence, and quality of life. In essence, we will have happier patients. And so our goal really is to reconnect the positive associations with eating and eating with others, even when an individual's physical needs have changed. So Reva is going to talk a bit more now about how we can specifically target improving food acceptance and dining health in the presence of dysphagia.
Thanks, Samantha. I'm just looking at this slide and I'm thinking, we need to expand it a bit because it's not only the emotional wants of a person, but also the caregiver too. And because a caregiver, based on the physical needs of the person with dysphagia, it all combines together into that overall all-encompassing dining health for the family or the unit. So I'm just going to briefly say that, I have done some work on the environmental factors. What can we do about the environment to increase acceptance of food with dysphagia? And I kind of coined it setting the stage, improving accessibility and modify as needed, making it social, reduce negative emotions of caregiver and individual through education and support. So to go into those areas in detail would require another presentation, and I'm sure we're not going to go into the deep of the night to talk further about that today. But I did provide a handout to Elizabeth to share with you that touches on some environmental tips, things that people can do at home. It was focused on a presentation that I gave to the ALS Association, but honestly, there's many different things there that really support the discussion that we're having today and the needs of people with dysphagia in general. So what I'm going to do instead is really talk about the texture modified foods. How can we improve the sensory appeal of these foods and improve the nutritional quality that we talked about before? So really, Aguilera and Park talked about, like, if you are going to design healthy foods, if you are going to get into food tech and try to improve things for the older adult, what are the different parameters that you have to look at? Well, it covers many of the things that we're talking about today, but it's, you know, they talked about the dysphagia, mastication issues, the loss of sensory perception and appetite, nutritional needs, loss of muscular body mass and bone mass. And so really taking into account all those whys of why they might need a texture modified and special food diet, and how we have to take into account those things when we create the solution of the food itself. If we go a little bit further into dementia, we can see, well, on top of all that, we actually have eating behavior changes. And what I mean by that is that more of a grazing approach to eating less with, you know, indirect touch, like I said before, with cutlery, but preference for eating with your fingers, needing more verbal cues to continue that eating process. What are the stimulatory factors involved in getting someone to continue to eat because the person has changed? And I think the wrong approach would be to say, oh, we'll just have that person with dementia accept the food that's being presented to them. Instead, it should be the food itself needs to be modified to meet the needs and the changed needs and behaviors of that person with dementia. So in light of that, Ballesteros and Pomar in 2020 came up with some recommendations for changes in the texture modified foods presented to people for dementia. They said, and this was a panel, an expert panel of individuals across the world, essentially, that talked about therapeutic foods. And what they called therapeutic foods were foods that are specially made and nutritionally enriched texture modified foods. That the foods that we develop need to be enhanced with energy and protein dense ingredients. We need to now think about those variety of options. As Samantha was saying, everyone has a different preference. If you only offer one solution, you're going to get a hit and a miss. So we need to have more variety, not only for that reason, but we as human beings prefer varieties. There's only one reason why there's 31 flavors at Baskin-Robbins. And we need to have increased food attractiveness and increased diversity and offer a range of protein and energy dense in between meal snacks. So this idea of how do people eat, what, you know, their classical traditional patterns of 3 meals a day might not be appropriate for people with dementia. And when I look at my dental literature, I have an input here where it's really important to start thinking about loss of mastication. What we look at there is, if you lose teeth, you lose mastication. And in losing mastication ability and efficiency, you develop cognitive decline. And this is being reported in animal studies and in human studies. So if we know that from the dental literature, then we have to look at is not loss of teeth, but a texture modified diet, because in a sense, you're stopping mastication, you're reducing the need to masticate for safety. But what is the impact of that as far as the end result on cognitive decline? And I would say that if we are looking at food technology, what I think we should look at is how do we create mastication, but in a safe way for someone with dysphagia? And that's honestly, that's the twist, the interest that I have. Now, Pillay and Karani just recently, last month, published an article that I think is really interesting. And they both talk about this acoustic stimulation loss with texture modified food. So you remember the 5 senses and the sense of hearing, that crunch from that popcorn, that image of that popcorn, the image of all these foods have that crunch. Well, it's that texture enjoyment through sound that is lost with the texture modified foods. And they go into detail about all the studies that are being done that relate to this and how difficult it is to assess this in a research modality. But people are trying to do different things of interest, like another tip to the environment. You're eating a modified texture diet that doesn't have acoustic stimulation. And that relates to taste, and that relates to texture, and that relates to your sense of perception of enjoyment. And so what they do is they play sounds that are crunchy sounds that are the crunchy sounds of the food prior to it being modified to help increase the hedonic pleasure of eating that food, which I think is really novel. So people are starting to think more about this. Now, my area of interest is in the area of transitional state foods. Why? It's because these foods are really unique. In this IDDSI diagram, the International Dysphagia Diet Standardization Initiative, and you can go to their website, IDDSI.org, to look further into this. But really, transitional foods are foods that start as one texture, but change into another with moisture, water or saliva, or temperature change. There's no biting or minimal chewing is required, just simple tongue pressure alone, and there's no size restriction, and the degree of transition is variable. So let's just dive further. What are these things called transitional foods? Well, these transitional foods can be solids, that acoustic stimulation of a solid that fits into this IDDSI model is extremely interesting. And these are crispy meltables, right? So if we look at transitional state foods, historically, we go into, the first finger foods for children. And now there's a move. Like, why are we keeping this classically and exclusively now in modern day to the pediatric population, pediatric feeding disorders, or even the typically progressing, typically developing child? What about adults? Adults can enjoy crisp, dissolvable, or crispy, meltable foods. And that's where I started to develop these savories, crackers, or crisps, because we want that transitional, start as a solid and change texture to a softer texture. And every product behaves differently. But in looking at the flip side of transitional foods, we have solid gels or liquids. And believe it or not, your ice chips are transitional foods. Magic Cup, which is something that is a frozen food, but it doesn't go to a thin liquid like ice cream does. It goes to a pudding. Ice cream is actually still considered a transitional food because it transitions in the mouth to a different texture. And dysphagia, Japanese dysphagia training jelly, which isn't really available in the US. So the value of transitional foods is this. You put the food in your mouth, you can see the hand, so that finger food approach. Think of that dementia population, but also the pleasure of eating with your fingers goes across all ages, and it goes across health and disease states. The ease of eating with your fingers is available to someone through transitional foods. But the pleasure of it arises from a confidence building and a reduction of fear in that it dissolves in the mouth. And in this diagram of the savories, it dissolves to a puree in the mouth for ease of swallowing. So let's go further. Why is this such a cool food group within the IDDSI framework? Well, it's the only food group within that IDDSI framework that fits within the classification of a finger food, which fits within what Samantha was saying as snack foods, an area that people, we need to look at the adult population and look at the ways that they're eating and how do we make snacks for people with dysphagia and make them safe. So transitional foods, like I said, they're finger foods, right? So research is being done to show that people that touch the food with their fingers actually eat more food and also display more a pleasurable, positive sensory experience. The brain actually thinks it's tastier and more satisfying before it actually goes to the mouth. And you can see here in a hospital setting, you can have transitional foods along with a food tray, and you can take that transitional food, which is a finger food, and you can dip it into the puree. You can eat it on its own. So it increases access of different ways of consuming that puree meal or eaten alone as a separate snack to graze on. As we said with dementia, a very important attribute, a grazing food to match their changed eating behaviors. So studies have been done. Why are we increasing snacking in hospital-based care? Why are we increasing it in facility-based care? Well, because if we change the opportunities to eat from 3 times a day to 5 to 6 times a day, then we can support these changed eating behaviors and increase overall daily consumption of food, increase body weight, and decrease length of stay. But it also can increase in eating independence. Think finger foods, and the ability to self-feed is such an important property. So really what I would like to say is when we think of these transitional foods, in the past, the weakness of transitional foods is a lot of times they don't have a lot of nutritional benefit. And now products need to be made. The mandate is if we are going to change to 5 to 6 meals a day because we are going to start looking at that individual and seeing their patterns of eating, let's try to make each meal as contributory to their protein intake, to their food intake, to their vegetable intake, to positive intakes of foods, as opposed to just highly processed and a lot of sugar. And that's exactly the approach that I took, and I would like to, mention with you is that we can take that approach. It is possible with enough energy devoted to development of foods and food technology. We can start looking at foods for dysphagia and start mandating for change. So snacking, it's a viable opportunity to increase nutrient intake in facility care that has been actually proven in a study done by at University of Oregon with David Bain and Samantha Schoon, and I participated in the study as well, looking at nutrient intake in facility-based care during snack time. So we looked at 2 8-week blocks of time. It was a crossover study between regular snacks that they typically consume, like applesauce, and it wasn't just texture modified snacks, but it was general snacks in as a long-term care facility. And then we also looked at sensory enhanced fortified savory snacks, which is kind of a safe for all approach. So it was available to all people, including people with dysphagia. So in the regular snacks category, we had, as it occurs in all facilities, that differentiated, dysphagia safe foods as well as regular foods. And then we did a separate block where it was just really the savories foods, which is all inclusive for everybody. And we weighed the snacks before and after the session in both 8-week blocks of time. And so what was looked at was the macronutrient and micronutrient content. And what we saw was the enhanced snacks led to an increased consumption of proteins and fats and fewer carbohydrates, including sugar. And there was no difference in caloric intake. So what was really exciting here in this, this small group of population of 10 residents that were studied, what we saw was that you didn't have to eat as much food in order to gain your caloric intake, which, as we know, like reduction of food intake is an issue, and we want to maintain nutritional value even though there's a risk of reduced intake, such as plate waste. So let's just talk a little bit about floor stock. If we're looking at snacks within facilities, we oftentimes are looking at what's on the floor stock, what's in the pantry, what is perhaps, they have different approaches at the nursing station. And oftentimes we'll look at shelf-stable foods, but they sometimes have foods in the refrigerator as well, or the freezer. So I'm giving an overall view based on our IDDSI group and looking at different floor stocks across the country. We see commonality. There's shakes and puddings and yogurts, applesauce, puddings that are either a fortified pudding or a not fortified pudding, gelatin, ice cream, soft cookies. And the problem with all of these they were all focused on the high sugar. There's flavor monotony. They're heavily processed. And, there's a high dairy incidence, which you might have a dairy intolerance, or it can lead to constipation for many of our adult patients. So what we did was we tried to look at these snacks, right? And we wanted to look at safety of these snacks. And we did a study that compared the behavior of transitional state foods under varying oral conditions. Why this was interesting to us was the fact that IDDSI actually says in order to assess a transitional food, and again, please go to the IDDSI website to look at the methodology for testing foods in specific transitional state foods, and you'll see that it is essentially a 1.5 centimeter by 1.5 centimeter cube that is cut out of a transitional food sample. So it's a uniform cube, if you will, of food that's put in 1 milliliter of water for 1 minute. And after that, you take a fork and do the standard fork pressure test, which means that you depress the fork into the food and make sure that the food is deformed, it doesn't return back to its original form, or has changed shape and had some form of deformation. Now, what we wanted to say is, hey, that's great with water, but what actually happens in the mouth? Does food typically transition in the mouth that transitioned appropriately in water? Because a mouth environment, as we were talking about, saliva is very different from a benchtop water in a vial approach. So we decided to study the savories, crisp, the crisp and the dip, shrimp chips, baby mums, and the eat bar, which is a yogurt coated meringue bar, a foam bar. So what we did was in this study, we wanted to answer the question, how is a dissolution of these solid foams occurring in mouth conditions? And do different transitional foods perform differently based on the IDDSI transitional food test? So what we did was we looked at 30 individuals. They're all adult individuals. And it was a study where we looked at 5 seconds of time in the mouth with no tongue pressure, 5 seconds in the mouth with modest tongue pressure using an IOP bulb as a kind of like a calibration tool for that individual. Before they put the food in the mouth, they use that IOP bulb to develop a moderate tongue pressure, which was equivalent to the same pressure that's used in the fork pressure test, which is 75 kilopascals of pressure. So we kind of calibrated everybody, and then in separate booths, people tried all those products individually with time in between each product for the saliva to normalize and for their mouth to normalize. And they used these conditions: 5 seconds in the mouth, no tongue pressure, 5 seconds with tongue pressure, 12 seconds with tongue pressure, and then uniquely 12 seconds with this pulsing up down of the tongue against the food, which typically occurs when food goes into a mouth in a more natural occurrence. And so what we saw was great diversity in the dissolution patterns. How often did these result in a positive fork pressure test? So these people expectorated after each sample at each time and pressure condition. And then we measured it using the fork pressure test to see, hey, did this thing actually deform and not return back to its original form? And you can see here there was quite a bit of disparity between consistent positive fork pressure test, this thing passed the transitional food test, to it didn't really pass a transitional food test very consistently. So we said, okay, well, these are widely varying results with transitional foods in the mouth. What happens when we do the classic benchtop test with IDDSI, which is that 1.5 centimeters by 1.5 centimeters for 1 minute in 1 cc of water, and then fork pressure test. And we saw here that there was quite a bit less variation in the degree of positive fork pressure tests that we got. You can see here the baby mum one was really, really not a transitional food. So the study conclusions were that there's wide variability in degree and speed of dissolution. So we need to have that heads up that not all transitional foods behave the same in the oral environment. We actually looked at saliva quantity in the mouth, and saliva quantity was a factor for some of the transitional foods, but not for all, because some transitional foods actually stimulated saliva flow. And when you have the dynamism of a pulsing tongue pressure, it actually improved the dissolution pattern. And so really, the fork pressure test gives positive results more often on benchtop than in the mouth. So we really feel that food trials happening in the mouth with transitional foods is really important. You know, assessing that dissolution on an individual basis is really important, and really something that's a big take home for takeaway for SLPs. So really the tips on implementation of transitional foods: start with samples. You know, get samples. In my opinion, I feel like I want to offer all SLPs free samples. I want you to really understand how this texture behaves, because it is so novel for adults, but it can be so beneficial in so many ways. So if you go to my website, you can download, you can click on this, well, you can enter this into your browser, and you can get free samples on my website, and we will ship those to you in variety of flavors with some informational material, so that you and your colleagues can just, you know, try it amongst yourselves, learn from yourself, and then start to think about samples for your patients. And really start to think about what are the best uses in your patient population, and look at the variability of options, or opportunities, I should say. The next step on transitional foods is education. You as SLPs are at the forefront of being able to educate your peers on texture and on transitional foods. And people want to know, food service wants to know, the dietitians want to know. We want to collaborate with them. We want to collaborate with other staff members. And of course, we want to educate appropriately our patients on when it is safe for them to have transitional foods. And one big misnomer is it's not what the food starts as with transitional foods. You know, most transitional foods on the solid foam category are a regular 7 food. They're a regular food. But it's really what it transitions to in your patient's mouth that's the most important before the swallow. And it can actually provide a unique opportunity to help patients with lateral tongue movement, with bolus formation, and really assist that patient in therapy. So listen to the caregiver and your patient needs. Is texture a real important part of their eating experience? Were they crunchers and chewers? Is this going to be a factor that is going to psychosocially improve their quality of life and the dining experience? And also, can you make recommendations? Can you implement into therapy? So here is an example of an implementation pattern into therapy. You could use food samples in your food trial, whether it's an instrumental examination. There are multiple SLPs that are using transitional foods in these studies and in modified barium swallow studies. And then also in your clinical swallowing evaluation, you can offer food trials with transitional foods. The safest approach is to have the transitional food assessed with the SLP. And then you make that recommendation. Can transitional food be added to your recommendations? Because in a sense, it's liberalizing the diet for that person. That person might be on a level 6 or a level 5 or a level 4, but they might be able to have a transitional food, and all of a sudden it increases their choices and the variability in their diet and their quality of life. So really, you can provide the recommendations in a nutrition plan, or provide advice to the team members, or to in-home health situations with a caregiver. And multiple times I've received information from caregivers who just say, you know, they just want acceptance of that meal. I mean, having something ready-made that decreases that food preparation burden is a pleasure for them. Having a person willingly eat the food is really a relief for many caregivers. And this last part is therapy, a novel approach to rehabilitation of chewing or swallowing, using real food as part of that rehabilitation or the therapeutic process. So here I want to share with you an off-hour stock template. I've given Elizabeth something that we've been working on with IDDSI. And this is really a modifiable template. So you can see, how can we categorize foods that are on our floor stock? How can we safely assign foods into different categories? Many people are transitioning towards IDDSI, and this is a way to facilitate when we look at that floor stock, so that everyone on the team can say, okay, this food is appropriate for this category. There's a lot of education behind this that I've also attached that will help guide you, but I'm also available to answer any questions you might have. But categorization is part of that education of your team members, and bringing on alongside this idea of liberalization of the diet and variety, looking at those ideas that Samantha said, if some people want savory, some people want sweet. How do we quickly look and see, what do we have in our availability in those different taste categories? So work with dietitians and other healthcare providers. You know, I'm actually going to let's see here. Yeah, I'm just going to talk a little bit about a summation before I just finally hand off to Samantha to give her summation of her tips related to the area that she discussed. But really, eating and meal times, this is really important to understand the balance between nutrition and food-related quality of life. Explore opportunities for increased safe snacking. Use that floor stock guide that I've provided to start having that conversation. And you can use snacking not only on the floor stock, but also on meal trays or in home to stock their pantry, giving them more options to eat healthy foods when they are ready to eat. And discuss the value of filling the gaps that we're now seeing in those puree, minced, moist, and soft and bite-sized categories that can be done with transitional foods. And offer increased variety and option. See if it's an appropriate snacking option and what therapeutic role it can have in diet advancement. Reconsider your assessment protocols. Look at, you know, as Samantha's I'm actually gonna shift off to Samantha so she can talk a little bit about these protocols.
Yeah, thank you, Reva. And so just to end with our last few minutes here, as Reva mentioned, we have to reconsider our assessment protocols. I'll talk a bit more about caregiver burden in a moment, but we really need to make a point to be exploring the consequences of the dysphagia in a more comprehensive manner. It's not just about impairment and safety when it comes to eating, but really about reducing the negative impact of disease on the individual with dysphagia as well as on their caregiver. So how can we change our clinical practices? How can we be maximizing our impact on the individual when it comes to overall eating and dining? Most fundamentally, we must make sure our interventions are person-centered. We need to be maximizing environmental familiarity, and this means across the senses, so not just the physical environment, the visual environment, smells, touch. I love that example of the candle that Elizabeth said before. How can we make the environment as familiar as possible? Certainly, we have to engage patients and caregivers in conversation and collaborative goal setting. This should not be us as clinicians telling a patient or telling a caregiver what to do. We need to be engaging in those conversations because that's truly person-centered care rather than healthcare-centered care or disease-centered care. I think as part of that collaborative goal setting process, and if you're not familiar with collaborative goal setting or motivational interviewing techniques, I would definitely encourage you to look into that a little more. But as part of that process, we can have conversations about individualized risks versus benefits. We can help inform patient decisions. We can help add information to patient decisions. But at the end of the day, we do have to consider autonomy when a patient is cognitively able to be making those decisions themselves. And certainly we have to remember the socialization aspect of meal times. We cannot reduce dysphagia to just the modified barium swallow image that we see. We have to take into account all the other socialization pieces that happen as a part of that mealtime process and integrate that into our assessment, ask those questions, and into our treatments. Then overall, we really have to be practicing person and family-centered care. Are we setting both the patients and their caregivers up for success? We want to foster success instead of failures. So first, identifying dysphagia early is the prime opportunity for us to get involved before the burden of care becomes too much to manage. We want to be providing tailored education to both the caregiver and the care recipient. Do this verbally, do this on paper, multiple modalities so they're getting this information. We can't be bombarding caregivers with information. We have to select pieces and do it in small bits at a time. We need to ask caregivers, do they feel capable of carrying out the necessary caregiver duties? So often we make assumptions about what caregivers are willing to do or what caregivers will do. At some point, we need to ask that. We should avoid using medical jargon when talking to patients and caregivers. And then finally, we have to be a bridge for services. So for example, counseling sessions with a caregiver could take place at the same time as therapy sessions for a client. So to end, I just offer here one tool. My lab recently developed the CARES as part of a multidisciplinary collaborative effort. It's a tool to help screen for possible dysphagia-related caregiver burden, and then to facilitate these important conversations with caregivers and really identify, are there opportunities for us to get more involved with the caregiver? Like, for example, do they feel like they need more information on modifying textures or safety? Or perhaps they need referrals to counseling. And so this is a new tool, a new validated tool you can certainly check out. And then for those of you in the pediatric realm, I did want to bring your attention to a tool that is also available for that population. And so to conclude, we don't eat nutrition, we eat food. As long as we continue to feed people nutrition and not food, we are reducing the joy of eating and increasing food avoidance, depression, risky eating choices, and for many, malnutrition. Ultimately, developing synchronicity between the wants and needs really is a key to treatment success. And so we thank you all for hanging in with us here. We know we went a little long today. We are happy to answer any additional questions. Our contact information is available as well, so feel free to reach out, and we can continue these conversations after tonight as well.
Samantha and Reva, thank you so much for presenting tonight. I'm going to take back the screen here from you if that's okay. And I will certainly send along some of the questions that we have. I think a lot of them were answered throughout the presentation, which is fantastic. But there's a couple that are coming in at the end here, and I'm happy to forward those to you so that we can respond over the next few days or so.
Reva and Samantha, I want to thank you, but I have a question. Given the reduced nutritional value in pureed food, do you recommend a daily multivitamin?
Yeah, I think that I mean, honestly, I would leave that to the dietitian to kind of talk to each individual to see what their risk factors are and what kind of vitamins that would be appropriate for them. I certainly am of the opinion that a multivitamin is, you know, a great thing for all of us to include, but you know, really diving deep into what are the situations for that individual. I actually think this idea of creating your own shakes that have like multiple colors in it, and actually putting pea protein or whey protein if you can tolerate it. There's even rice protein that's come out, and having those kind of things as being a part of it to reduce the risk of sarcopenia is really important. So yeah, so I think it's a combination of those micro and macronutrients, and bringing alongside the dietitian to give the final advice as to what's the best approach from that regard.
Thank you for that. I'm gonna wrap this up. Reva and Samantha, thank you so much. The questions and comments that have come in have shown that your work has really opened the eyes of many people, and they'll be bringing that back to their facilities. So,
well, thank you, Ed and Elizabeth. I think I can say that it was just a real pleasure, and especially for Dysphagia Awareness Month. I'm just thrilled to be a part of this. So thank you. Which was awesome. Yeah.
So to all of our participants, I want to thank you for attending tonight's webinar presentation. If you had a question that wasn't answered, please email us. Our email address is on the screen. You can pass those to Reva and Samantha. And within an hour or about tomorrow morning, you will see a survey in your inbox. It takes a minute or two to fill out, but it helps guide us in what types of webinars to do in the future. So with that, I'd like to wish you a good evening, or if you're in another part of the world, a good morning, and I hope that to see you for our next webinar. Good night, everyone.